Okay, good morning. My name is Christine Andeni, and I'm one of the co-directors of Grand Rounds, along with Dr. Jeff Miller and Dr. Kate Elkington. We have a few announcements before we begin today. There will be no Grand Rounds next week, as it is Yom Kippur. Grand Rounds will resume on October 12th. Dr. Warren Ng will be presenting, and the title of his talk is Beloved Community Systems That Care. For today, we would like to remind everyone to post questions at any time during the talk using the Q&A feature at the bottom of the Zoom window. This is separate from the chat. Also, if you are a trainee, please put the word trainee at the beginning of the question as we prioritize trainee questions. You can also please write "can ask question myself" or prefer to have my question read at the end of your question. If you are willing to ask the question yourself, we will promote you to a panelist so that you can ask your question directly to our speaker and your camera can be on or off as you prefer. Asking your question yourself adds to a sense of our community and connection during our Zoom sessions, and so we encourage you to do so. Our speaker today is Dr. Leopoldo Cabassa, and the title of his talk is A Call to Action: Reducing Racial and Ethnic Health Inequalities in People with Serious Mental Illness. Today, we actually have the introduction by Dr. Roberto Luis Fernandez, but he is away, so we have a pre-recorded video. And I'm now going to pass the meeting over to Simon to start the video.
My name is Roberto Luis Fernandez, and I am director of the NYSPI Center of Excellence for Cultural Competence and a professor in the Psychiatry department. It is a true pleasure to introduce Leopoldo Cabassa, today's Grand Round speaker, whose presentation is part of the activities for Hispanic Heritage Month. Unfortunately, I cannot attend in real time since I'm giving a talk at an OMH retreat in Albany. Thanks to Simon Williamson, I recorded this introduction a couple of days ago. Leo is a professor, director of the Social Work PhD program, and co-director of the Center for Mental Health Services Research at the George Warren Brown School of Social Work at Washington University in St. Louis. I've known Leo since 2003 through our mutual colleague and Leo's mentor, Luis Sayas, who introduced us when Leo was a grad student. I have a vivid memory of how enthusiastic Luis was about Leo's promise as a researcher. So when OMH founded our Center of Excellence, I sought out Leo to be its assistant director, which he did in his usual exceptional way from 2009 to 2016, when he took a full-time faculty position at his alma mater, the Brown School at Washington University. We have continued to collaborate ever since, and Leo has forged many other collaborations in New York, nationally and internationally, including with Lisa Dixon, Scott Stroop, Ezra Susser, and many others in our department. One of Leo's virtues is his constancy, which includes loyalty to his colleagues, sustained engagement with his students, sometimes over decades, and commitment to his people, including back in Puerto Rico. In fulfillment of Luis's hopes, Leo has already become one of the most productive and impactful Latinx mental health researchers in the US, and he is just getting started. His work has focused on three areas at the intersection of implementation science, community-based participatory research, epidemiology, and intervention research. First area is improving depression literacy and reducing stigma towards mental illness in the Latinx community, for example, through culturally congruent psychoeducation approaches. His second area is reducing physical health disparities in ethno-racial minorities with serious mental illness, including developing interventions to reduce early mortality from cardiovascular disease and diabetes. His third area is improving the health and well-being of young adults experiencing first episode psychosis, for example, by clarifying their pathways to care. He is an outstanding representative of research with Latinx communities and we are honored to have him present during Hispanic Heritage Month. His talk today is entitled A Call to Action, Reducing Racial and Ethnic Health Inequities in People with Serious Mental Illness. Please welcome Leopoldo Cabassa.
So first of all, muy buenos días. It is an honor to be here and really heartfelt thank you to Roberto and the leadership at PI and Columbia Psychiatry for that great introduction. I am honored to be here and to share the work that we're doing. Let me start sharing my slides so that we can get started. There we go. And let's get this going. All right. So it is a big honor to be here today, and I want to thank everyone who provided support for this work. Before I start, I do want to acknowledge that the work that I'm doing today represents the work of many different people, and part of what I love about my job as a scientist and an implementation scientist in particular is that this is a team sport. It is an opportunity to work with people from different backgrounds, different disciplines, and different life experiences. And the work that I'm presenting today here is really a testament of the work of all these great individuals that I get a chance to collaborate and work with. I've also been very fortunate to be funded by the National Institute of Health, the New York State Office of Mental Health, and more recently by some internal grants from Washington University in St. Louis. I also want to thank and put mil gracias out there for my Columbia Psychiatry, CSC, CPI, OPA, and NYSPI. I know how in PI people love the acronyms, and I've been very fortunate in my career to be able to work with some great individuals who are part of Columbia Psychiatry and PI, and I've learned enormously from them. And even during these past 3 years that we've been sort of in a virtual world, our collaborations have not only continued to grow, but to strengthen over the years. And part of the work that I'm going to present to you today is a testament also to the hard work of all the individuals presented here. And I'm missing Ezra. It's the only person I couldn't find a good photo on, but Ezra has also been an excellent partner in this work. So let's get started. As many of you know, and this might be the understatement of the year, we are living through unprecedented times. COVID-19 continues to infect and kill millions of people around the world. The uprising for racial and social justice ignited by a century of structural racism and injustices, and the murders of Michael Brown, George Floyd, Breonna Taylor, and countless others, que en paz descansen, at the hands of police officers in the US, as well as the injustice and the increasing anti-immigrant attitudes and policies that have taken root in the United States against people from Latin America and the Caribbean. And on top of this, we are continuing to live, to suffer from the neglectful colonial policies of the US against 3 million Americans in Puerto Rico who are treated as second-class citizens in their own land. All of the things, the confluence of all of these injustices have really pulled back the curtains and clearly revealed the deep social, economic, political, and health inequities that have taken root in our society and how directly it impacts everyone's life. Over the past decade, my team and I, and many of the people that were here before, we've been doing studies and trying to address the health inequities in minoritized and historically marginalized community, particularly those from Latin American backgrounds residing in the United States and recovering and living with serious mental illness. And the quote that I started this talk with is actually from a classic and seminal report on the morbidity and mortality of people with serious mental illness, that there are multiple strategies to pursue to addressing the morbidity and mortality of this population. But for any of these strategies to be successful, our principal partnership must be with the people we serve. So my goal today in this presentation is to show how our team over the past decade has tried to put this value into action to inform the science that we're doing. And this to me has become a really important discussion that we need to have, because health equity has gotten a lot of attention recently because of all the things that I have talked about. But we are not talking about how we go about doing our science and the importance of not forgetting who are we serving, who is our science for, and the benefit that our science can have to address the inequities. For each of the areas that I'm going to talk about today, I also want to ground my work in the stories of the people that we are serving. So you're going to hear stories of each individual on different areas that I'm going to talk about today. The stories tell us it's a good way of communicating, not only about the science that we're doing, but how we go about doing our science and the realities and the voices of the people we're trying to serve. And in the words of a good mentor of mine, as Roberto mentioned, Luis Sayas, data cannot be allowed to eclipse the humanity of the work that we do. So I want to ground some of the work that we do also in the stories and the lives of people that we're trying to help and address with our science. So let's start with the story from Carla. Carla was someone that I met many years ago doing a focus group. Part of the work that I do, we do a lot of qualitative work. And it was part of a focus group discussion we were conducting actually at a public mental health clinic in New York City to learn about the physical health issues and the healthcare experiences of people with serious mental illness, particularly people from Latin America. Carla was born in the Dominican Republic, but had lived most of her life in New York City. She spoke English and Spanish, but preferred to speak in Spanish. And at the time that she participated in our work, she was living alone in an apartment in Upper Manhattan. During our discussion, when we asked people to describe their health, this is what Carla indicated to us. I'm sick from head to toe. I have many problems. I have diabetes, high blood pressure. My mind is not right either. And I also have really bad arthritis that I had for a long time. Carla was someone that was deeply engaged in primary care. She had access to primary care services. She visited her primary care services. She visited her psychiatrist at a public outpatient mental health clinic, but she felt like she was not getting the care that she needed. Like many of the participants in our study, she described these clinics as always full of patients, staff that seemed overburdened and rushed, and she could never get enough time to talk to her doctor and mental health provider about her medical conditions and the questions that she had about treatment. She worried deeply about the medications that she was taking, particularly those that were impacting her weight. And she knew that this was bad for her health, and making her diabetes and hypertension worse. But she did not have anyone to help her balance the treatment she was receiving from her health and mental health doctors as well. And although her psychiatrist and her primary care doctor recommended that she lose weight, take her medications as prescribed, take better care of herself, they provided little support or concrete strategies to accomplish these lofty goals in the environments that she was living in, the neighborhoods that she was living. So Carla talked about how she tried many things over the year, but nothing seemed to work or nothing seemed to stick. And she had truly lost confidence in the trust of the healthcare system because of the negative experience that she had lived through. Carla died of a stroke about a year later from our discussion. And she died of preventable medical condition that consumed her from head to toe. Carla's untimely death, like thousands of people with serious mental illness die each year in the US from preventable and treatable medical conditions. It's a truly national tragedy. And the work that we're trying to do is to really address this inequity in premature mortality among people with serious mental illness and build on the work of many other people that are trying to address this huge inequity in our population. So as I go through my presentation today, do think about Carla and her experiences and how we're trying to help her through this process. So as many of you know, people with serious mental illness are basically disorders that interfere with major life activity, results in serious functional limitation. This includes schizophrenia, bipolar disorder, major depression. Around 14.2 million adults in the US report a serious mental illness in the past year. Serious mental illness constitutes 5 out of the 10 leading causes of disability worldwide, but recovery is possible with the right supports and the right treatments. And it is up to us as mental health providers to help people with their recovery and live productive lives through this process. As many of you know, people with serious mental illness, like Carla, are facing serious medical conditions. They're dying at a much younger age than the rest of the population. Depending on the studies that you look at, it's between 13 to 30 years early, largely due to cardiovascular disease, to the illnesses that are impacting the general population, but they're impacting this particular population at a much earlier age. In terms of Latinos with serious mental illness, there is some emerging evidence indicating that there's a double health burden for Latinos with serious mental illness compared to non-Hispanic whites. There's evidence of increased risk of cardiovascular related mortality, diabetes, metabolic syndrome, and obesity. But this literature actually is very inconclusive. Most of the studies are use small samples, mostly are clinical sample. We don't have great data on this from community samples. And few actually stratify by subgroups, by different Latino groups and gender, which we know are impacting issues like diabetes, cardiovascular disease, hypertension. So we need more data and more examination of these inequities. COVID-19, as mentioned by Wen and colleagues, has become an acute on a chronic problem. And there is emerging evidence how COVID is disproportionately impacting historically marginalized and racial communities in the United States. This is just one of many of the emerging evidence that's emerging regarding these inequities and that are exacerbating existing health and healthcare inequities, social conditions and structural vulnerabilities that impact this. And in this case is excess death by race and ethnicity between comparing 2015 to 2019 pre-pandemic in 2020. And you see every group has really impacted with a disproportion of excess deaths among Hispanics. We also have seen evidence emerging that people with serious mental illness are increased risk for acquiring and dying from COVID-19. So given all the inequities that are happening with people with serious mental illness on top of everything that's happening, add to this the risk that many people with serious mental illness live in congregate housing. Many of them are homeless. You have people living in nursing homes and other congregate solutions. You have, on top of the already public health crisis that is impacting this population, we have a hurricane really brewing among this. And we're beginning to see the impacts of this epidemic on this pandemic in this particular population. So another major component that what has shown is that COVID has also shown us the lack of implementation of evidence-based practices and the gap that we see between knowing what has shown the world basically, knowing what to do does not ensure doing what we know. And these are two great examples. One is from a New Yorker article from Atul Gandhi talking about the lack of and the problems that we had in this country, in the United States in particular, around testing. And the other one is actually a very impactful editorial in the journal Science by one of my former mentors and a great colleague, Enola Proctor and Alvin Gant, that really show the importance of addressing this major gap of the evidence that we have and how do we bring that evidence to communities that most need it. And COVID-19 has really highlighted the need for this type of work. We can create the best vaccines we have in the world, the best pills in the world, but if nobody takes them or not accessible to the communities that most need it, no one's going to benefit from them. So we need to pay close attention to how do we address that gap between the research and the practice that we have, and our team is trying to address that. In the area of Latinos with serious mental illness, we still see these persistent gaps. And I'll give you an example of two major ones that continue to haunt this literature and important areas that we need to continue to do work on. The first is that people like Carla are often excluded from the trials to establish the evidence in our communities. These are three separate systematic literature review examining lifestyle interventions for people with serious mental illness, peer-based intervention, health interventions for people with serious mental illness, and psychosocial interventions for smoking cessation. And in each of this systematic review, we were able to document a stark underrepresentation of racial and ethnic minoritized groups in these trials. As we've discussed in other publications, the exclusion of historically underserved communities in clinical trial creates a serious blind spot, not only in our treatment science, but in moving that science into action. We need to develop better evidence on how to make these models of care that we know work, how to make them work in communities that most need them and benefit those historically marginalized racial and ethnic communities. So we need more science to really address this issue and create better representation in the trials of generating the science. Another critical element that we're seeing in this literature, and in fact, there's a serious silence and inattention in our research literature that particularly in the health of people with serious mental illness regarding racial and ethnic diversity, institutionalized racism, and cultural factors. This is a great paper that reviewed many of the interventions that we have out there to address medical condition, health risks, behaviors among persons with serious mental illness. It's an excellent review of the evidence out there. Yet in this publication, there's not a single mention of the issues of race, ethnicity, racism, or culture. And these are serious issues because we know that each of these factors influence people's health behaviors, the diet, the physical activity. It influences their experiences with their illness. It shapes the client-provider interactions, how people interact with their mental health provider or primary care provider. And it also shapes the interactions that these communities have with the healthcare system. So these cultural and social determinants of health matter. We need to pay attention to it and begin to think how to integrate them into the services and the intervention that we're developing. So one approach we've been taking is focusing on equity rather than equality. And I want to make this point clear because, and this is one of the best pictures that I could think of that from the Robert Wood Johnson Foundation of the difference between what we mean by equality and equity. We work on equity. Equality, as you see here, focuses on providing everyone the same thing without considering their specific needs or circumstances. Equity, on the other hand, forces us to think about the unique needs of each individual. You can think of this of communities, of organizations, and examining what do they need to be successful based on their unique needs. A one size does not fit all to address health equity. We need to do different things to different people. We need to tailor our approaches, our intervention, our implementation strategies that address the complex determinants of health and of healthcare inequity. An equity lens forces us to ask about this difference, to explicitly target the unique needs of vulnerable communities, to focus on what they need for different community settings and population. So in our work, we've been using equity to address this issue in very specific aspects. One, we've been incorporating culture into the interventions that we are adapting and implementing, considering how culture shapes medical care, nutrition, physical activity. We are making a point of engaging racial and ethnic minoritized population in our study, meaning that the majority of people who participate in our study come from this community. We need studies for these communities, in our community, by our community. That's important to generate the evidence that we need and to address the stark underrepresentation in our treatment sciences. We're also expanding the type of providers who can deliver health interventions. In our case, as a social worker, we're trying to bring social workers more into this, and also working with peer specialists, people with lived experiences with serious mental illness and substance abuse disorder, how to train them so that they can also become people who can deliver this intervention. And in the work that we're doing, we're also expanding where we put this intervention. Instead of waiting for people to come to the hospitals or clinic, we're expanding them and bringing them out into the community. And then lastly, an important area of this is our research questions, as you will see, focus on integrating the interventions and services into routine practice setting. How do we bring these interventions out into the community? So how do we move this agenda forward? So as a social worker and trained social worker, we're always looking at the social ecology of the issues that impact the areas of research. In this case, the modifiable risk factors that contribute to health inequities in people with SMI. And we need to look at this not from the individual side, but across the multiple socio-ecological factors. So let me start with some work that we began. Actually, this began in New York. This was part of my care award, where we focus on medical care, of understanding and trying to address the gaps that happen in accessing medical care for people with serious mental illness. And most of the studies, as you will see, start with some qualitative data. Again, the stories are really important to ground in the realities of what we're trying to study. So this is a great quote from an administrator of a clinic that is really capturing, trying to capture the essence of how seeking and receiving medical care in many ways is like going through a complicated maze. Within our healthcare system in the United States, we force people to have to navigate from one system to the other and try to figure out how to get this access that you need. And this gets complicated. Imagine for someone that's having symptoms of psychosis, may not speak the language, are trying to figure out where to go. It can get overwhelming, as you can imagine, and patients get frustrated and they don't get the care that they need. So this is one of the areas where we've been trying to focus. How do we make sure that people get the care that they need when they need it? So our first call to action is that there are many different integrated models of care, and that this should be the norm, not the exception. People with serious mental illness should be receiving care in integrated models of care that bring physical and mental health services together. But these models need to consider the cultural and structural obstacles to care of particular communities, particular racial and ethnic minority communities, and examine how to address those cultural and structural obstacles to care. So in this work, what we did, we took an intervention that was developed by Ben Dross in Emory, mostly for Black patients. It's adapted from PCARE. It's a healthcare manager intervention. Basically, we're training, in our case, we're training social workers to become healthcare managers. And in the most basic form, healthcare managers, as you can see here, they serve as a bridge between the patients and their primary and mental health provider. They're creating partnership with all of them. They're ensuring that the patient's health issues are being properly identified, evaluated, treated, monitored, and managed. And this is someone that's helping that person navigate through that maze, back and forth between the systems. In the study that we did, we trained social worker, master level social worker, to become healthcare managers. These are people employed in a public outpatient mental health clinic and helping people navigate to primary care in their community. To do that, we knew that we needed to adapt the intervention, this great intervention that Ben and his colleague, Dr. Dross and his colleagues had created. We needed to adapt them to Latinos. At that time, that intervention was originally developed for African American, for Blacks in Atlanta. We wanted to adapt this to Latinos in Northern Manhattan. So for that, we use this approach of adapting the intervention with the community, this collaborative intervention planning framework, which is bringing people together, bringing the stakeholders and the researchers together to come up and figure out how do we adapt, how do we fit this intervention in the realities of the practice. And in its most basic form, there's two key elements of this approach. One, we use CBPR, community-based participatory principles, to foster that partnership between stakeholders. We use participatory processes. To do that, we value different sources of knowledge. The researchers bring knowledge, clinicians also bring knowledge and wisdom, community members also bring knowledge and wisdom. We bring all of that together, and we use a strength-based ecological perspective. So how do we make this intervention fit with the resources and the assets that exist within these clinics? And then to put those principles into action, we then use intervention mapping, which is a step-by-step approach of developing intervention or using theory to develop, and in this case, adapt an intervention in a rigorous manner, understanding sort of the type of adaptations. And it focuses on multiple sources of adaptation, not only adaptations to the clients, but also adaptation to the setting in which we're working in. And in this case, we needed to adapt this intervention to social workers, since the original intervention was developed with registered nurses. So that level of adaptation was really important. And to give you an example, and I'm not going to go into all the different adaptations, but this enabled us to identify both provider and cultural level adaptation. And I'll give you an example of a cultural adaptation that we did for clients and actually for providers as well, that focus on developing a personal health record and a patient activation checklist. This is basically a communication tool that organizes all of the health information of an individual in a very simple way. It facilitates the communication between providers and our treatment settings. And the idea is to enhance the client's self-management skills. So it's not only providing all of the information, what are the person's medications, what are their physical condition, it also providing them a list of questions to prepare them for their visit, to engage them in their visit. What should I do before I go to the doctor's office? What questions should I ask my doctor during every visit to make sure that the person is engaged in their own healthcare? And so this was a way of empowering Latino clients to engage in the care. And this addressed a major cultural issue that we're seeing in the Latino community, where patients tend to have this deference to authority of not questioning their doctor's order. This gives them an opportunity to engage and actually ask questions about their treatment. And think about Carla and the lack of trust and the frustration that she had with the healthcare that she was receiving. This is to address that frustration and empower them. We tested this intervention in a pre-post 12-month pre-post design and a public mental health clinic. This was predominantly serving Latino adults with SMI in New York City, mostly Dominicans and Puerto Rican. And we do structured interviews and medical child abstractions at baseline 6 and 12 months, and we follow people for that. And in every study that we do, we also do qualitative data. We wanted to examine also the client's experiences with our intervention and what did they actually learn and benefited from as well. And what we found was that social workers can do this. With the right support, the right supervision, social workers can become very effective healthcare managers. In fact, many of them already do a lot of healthcare management, but this gives them a structure of doing that. We found that 85% of our participants completed the intervention, this 12-month intervention. And over the course of the intervention, we saw significant improvements over time in patient activation, self-efficacy of talking to their doctor, managing their chronic illnesses, and it almost doubled the receipt of preventive primary care from 29.9% to 55% in it. But one of the things that we learned from this study by using qualitative data is what were the factors that really impacted this engagement that we saw in this population. And this is a quote from one of our clients, that the healthcare manager treated me like I was family. And what we were beginning to identify is that the healthcare managers had embedded all these cultural aspects that Latino clients value in their healthcare interaction, that they have a provider that shows them respect, respeto. Apoyo means support, that they feel supported by this individual, that they are giving them individual attention, that this person is professional in what they're doing, and that they engender trust. This is someone I can disclose information for, someone who's going to be helping me in addressing this component. So this began to unpack what is the cultural elements we embedded in this intervention. And from the client's perspective, this is what they were reporting as critical aspects for that engagement. However, this study had one failure, which was that it did not improve people's physical health. We were able to connect people to primary care, to receive preventive primary care, but their health really didn't improve. We didn't see any improvements in their weight, in their diabetes, in their hypertension. So this actually led us to then develop other studies that focus on health behavior. So we've done a study on medical care and focusing on that, and then really thinking about how do we help people with their health behavior that are directly linked to premature mortality in people with serious mental illness. So our second call to action within this is that when we are doing these health interventions, we need to think beyond the clinic's wall. How do we take interventions that we know work in the clinic? How do we make them work in the community and try to reduce the access disparities that we see and the access obstacles that we see in this population? So for this study, we actually partner with supportive housing agencies. It's a growing service sector that provide housing services and social services to people with serious mental illness. They're serving individuals with the highest risk regarding poverty, histories of homelessness, chronic and medical illnesses. This is an approach of bringing health intervention to where people live, to bring the interventions to people's doorstep. Many programs already are beginning to think about health and wellness. They see this as a major need. And many employ peer specialists, people with lived experiences. And that could be a really important workforce to help with the situation. In the trajectory of the study, we actually started from the voices on the community. And this is one example of how our team, really when we're thinking of a research question, we start with the voices from the community. So we developed this photo voice project. This is part of the New York State Center of Excellence in Cultural Competence that provided some initial funding for this. And photo voice, as many of you may know, is a participatory action research approach that entrusts people with cameras to document their everyday life, to inform social action. They enable people to tell us and actually show us what it is to live in their particular neighborhoods. It promotes a critical dialogue. So the value of photo voice is not only the photographs that are being generated, but the voices and also the stories behind those photographs and the dialogue that happens when we bring people together to talk about those photographs. And the idea is to promote that critical dialogue, knowledge of community issues, and then hopefully reach change agents and policy makers. These are really engaged methodology. And for our purposes, we really wanted to see what can we learn from this photo voice data in generating information about clients' preferences for health intervention. We learned three major things from this. One, clients wanted something around format, that it was peer-based. They wanted someone who has walked the walk, who had actually had been recovering from serious mental illness, were challenged with diabetes and chronic medical illness. They wanted someone that had that lived experience. They didn't want a professional lecturing them about how to do this. They wanted someone who can really talk from their own personal experiences how to address these issues. The content of the intervention, people wanted an intervention around weight loss, physical activity. They know that these were serious issues that they're facing. How do we address these issues? How do we increase our physical activity, improve our diet? And then lastly, the method. People wanted experiential learning approaches, skill acquisition. Tell me show me how to do it. Don't tell me what to do. So really practice that skill within their community, in the places that they live. So this participatory approach enables us to identify what were the client's preferences and then find interventions that address these issues for this population. So across many different projects, we ended up adapting the group lifestyle balance, which is an intervention developed by the Diabetes Prevention Program. It's a group intervention. It's 22 sessions, lasts about a year, and it focuses on improving dietary habits as well as increasing physical activity, finding a balance between your diet and your physical activity. It's been proven effective across multiple populations in many different trials, and we adapted it to supportive housing agencies and peer specialists with the developers of the group lifestyle intervention at the University of Pittsburgh. And based on that work, we actually then wrote an R01 and got this hybrid type 1 study called the Peer Healthy Lifestyle Program in Supportive Housing, which is a hybrid type 1 in which we're testing the effectiveness of this intervention. Does this intervention work in addressing the physical health issues of this population? But at the same time that we're doing that in a rigorous manner, we're also examining the implementation of that intervention within a supportive housing agency. So we get to learn two things. Does it work? And then how is it actually working in this setting? As I mentioned, PGLB is a 12-month, 22 session delivered by trained peer specialists that are trained and supervised by our research team. This was conducted in 3 supportive housing agencies, 2 in Philadelphia, 1 in New York City. We had a sample of 314 adults with SMI who were, at the time of enrollment, they had to be overweight or obese, a BMI of 25 or above. And we focused particularly on minoritized community, and 82% of our sample for racial and ethnic minority, mostly Black. Our measures were done at baseline and then post-randomization at 6, 12, and 18 months. We had an 80% retention rate at 18 months of collecting data. And our main outcome was clinical significant weight loss, whether the person lost 5% or more of their initial weight loss. And secondary outcomes were clinical significant improvement in cardiorespiratory fitness. Basically, are people increasing 50 meters in the 6-minute walking test that we provided. And then a reduction in CVD risk is a combination of clinical significant weight loss as well as clinical significant improvement in cardiorespiratory fitness. So this trial was conducted before COVID, and we actually finished right before the COVID pandemic. And what did we find? So we found no findings that although a larger proportion of our PGLB participants compared to usual care achieved clinical significant weight loss, increases in cardiorespiratory fitness and reduction in CVD risk, none of these differences at 18 months, which is at the end point of our trial, none of these were statistically significant. However, when we compare our peer-led healthy lifestyle intervention to other healthy lifestyle interventions that are being tested in this population of people with serious mental illness, we see that PGLB actually has comparable results among this population, particularly when we compare them to the great work that Gail Dahman has done at Johns Hopkins and the great work that Stephen Bartel is doing in SHAPE. That are some people in our trial benefited from this intervention, and we achieved similar results compared to other interventions. But remember, this is a hybrid 1 trial, so one of the questions and data that we were able to identify is like, so what happened here? If you have a null finding when you aggregate all the information from all your sites, what can you learn from this? And one of the things that we learned was that PGLB impact actually differ by study sites. At 2 sites, we saw similar null findings, but at one of the sites, PGLB consistently outperformed usual care at all time points, particularly the proportion achieving clinical significant weight loss at 18 months, 42% versus 22%, and clinical significant reduction in cardiovascular risk at 6 months and 12 months. So this really enabled us to then see, so what's going on here? What are some of the factors that may influence why this intervention works in one place and not other? And by having a hybrid design and collecting different types of information and mixed methodologies, we're able to begin to explore that question. So right after we had this finding, we actually got a small grant to use this new methodology developed by Bo Kim called the Matrix Multi-Case Study Methodology, which is basically a mixed method approach where you're identifying implementation factors and beginning to identify what may be related to the different differences that we're seeing across study sites. And in this case, we focus on fidelity. How well did we deliver the intervention per site? And then we examine 2 indicators of acceptability, basically satisfaction that the clients have to PGLB, satisfaction that the clients have to the usual cares delivered at each of the sites. And then we had some really interesting qualitative data that we had collected before we intervened, before we started the trial, and after the end of the trial, with the leaders of each organization, each of the sites, to see how well they had integrated the healthcare service throughout the trial. Remember, our comparison group was usual care. So one of the things that we observed in this trial is that people in usual care also did good, also benefited from usual care. Usual care actually was doing pretty good compared to our intervention. So we wanted to see, were there any changes in usual care over the course of our trial? And what we've begun to see, this is a paper we're currently in preparation with one of our great doctoral students and NIMH T32 fellow, Daniela Tuda, and our team, we're beginning to identify a pattern here, that the site where this worked best had the highest levels of fidelity, although if you see this data, this is pretty good fidelity. We saw that everyone was very satisfied with PGLB, so very little differences between sites on their satisfaction with PGLB. However, the site that had the site that benefited most from PGLB had the lowest level of satisfaction with usual care, and also had the lowest level of integration of healthcare services. So what this is beginning to identify for us is that the success of the PGLB intervention seemed to be related to high levels of fidelity and a clear relative advantage over usual care, particularly in settings that have not integrated healthcare services throughout in their setting. And that's an important component because it's helping us understand where kind of interventions seem to work best and why does it work in certain settings and not others as we're doing this. The other major component of our work here was that it also gave us an opportunity to examine why were peer specialists critical? They were helpful in engaging and motivating participants to engage in healthy lifestyle intervention. And this is a great paper, qualitative paper, led by Lauren Bochicho, who's a postdoc at Columbia School of Nursing, and our great collaborator, Dr. Ana Stefancic, who also participated in this trial. Is one of my closest collaborators at Columbia. And what this paper really began to identify were that the peer specialists not only brought their lived experience with SMI, they also brought their lived experiences addressing healthy lifestyle issues. How do they change their diet? How did they increase their physical activity? And they provided the support around feeling comfortable, helping clients the support and encouragement that they need, and continue to have that motivation and hope to move forward. And that those were critical elements here of how peer specialists really benefited, how clients benefited from the peer specialist engagement that they had. And so all of this really helped us identify. And we're doing more, really looking at this data to further identify how to best work with peer specialists, how to support them, how to train them, and how to provide them better supervision and opportunities to engage in this workforce. However, this study really highlighted for us, the past 2 studies that I've talked about, that to address the premature mortality of people with serious mental illness, we have to focus on treatment. We have to focus on helping people with their diabetes and their hypertension. But if we really want to reduce that premature mortality, we need to focus on prevention. We really need to think about how to address this way before these chronic medical illnesses take hold on people's lives. And this really was captured by an interview we did with Enrique. Enrique was in his mid-20s when we first met him several years ago. He described himself as Afro-Caribbean, meaning that his mother was Black and his father came from the Dominican Republic. He was diagnosed with schizophrenia in his early 20s. And at the time that we met him as part of these interviews, he talked about how he was beginning to get very concerned about his physical health. He knew he was taking antipsychotic medications, which were helping him with the voices that was hearing in his head, keeping him outside of the hospital. He was living in the community, getting treatment, but he was getting deeply concerned about the weight that he was gaining from this medication. And he was concerned that what can he do with this situation? And when he described this dilemma, he described it like this: this medication, it cures you in one way, but it damages you in another way. And this is sort of a classic example of what we need to do with young people that have emerging serious mental illness, in the beginning stages of their mental illness, that is a great opportunity. It's a critical period to address their physical health issues as well, and hopefully set them in a path for health promotion, no health inequities. So in this work, we're beginning to think about how to deliver interventions to these young people that focus both on the community aspects and the medical care component as well, and the health behavior. So the call to action in this area is not just to screen and monitor, which is what we usually do in mental health setting, but to intervene from the very beginning, not only to screen whether the person has high risk for X, Y, and Z, and monitor what's happening with their glucose levels or the lipid. That's really important, but we also need to make sure that we're intervening and providing them the services that they need at these early stages, and focus on health promotion. And there is emerging evidence in this area that early psychosis is a critical period for addressing emerging cardiometabolic risk. Between 50 to 80% of young people with early psychosis or emerging serious mental illness experience 7% weight gain during their first year of treatment. And this not only is impacting their physical health, it also impacts their mental health. This is one of the reasons people stop taking medication or disengage from care. There's also evidence of trends of worsening metabolic indicators for those receiving antipsychotic medication, and particularly among racial and ethnic minority, who may bring higher risk for issues like diabetes and hypertension. These medications can also impact their physical health without the right supports. There's also high rates of tobacco use in this population. And what we're finding is that there's evidence-based interventions to prevent cardiometabolic risk in young people, but they're not being widely implemented in routine practice settings. And that's the area that we're trying to address with this emerging area. So one specific service setting that we want to really try to integrate this physical health component is in coordinated specialty care, where many of you are well familiar of the service setting and this work. And what we have right now is a work in progress being led by Anna Stefanczyk here at Columbia University that focus on how do we embed health promotion practices into coordinated specialty care, focusing both on care management and coordination, but also having a focus on health promotion and prevention, providing healthy lifestyle that is tailored to young people and young adults with FEP, provide free access to tobacco cessation programs, peer support to help with the health promotion, and figuring out ways to do it in a flexible manner, in person or virtual or one-on-one or in group or a combination of all the things. And then focus on minoritized racial and ethnic groups. We currently have an R34 that Anna is currently literally revising and resubmitting soon. And the idea here is to work with our partner community in On Track New York to see how we can best embed health promotion practice, to see what works, what could work in this setting. And again, this is not a new problem. This is an old problem we have known. This is what you see here is a positive cardiometabolic health, basically treatment algorithm for early intervention framework for patients with psychiatric medications. This is more than 10 years old now. We know what we need to do. The challenge that we're facing is how do we shift the focus of care to include and value health promotion within the great mental health that we're providing in coordinated specialty care. And the idea here and the sentiment that we want to address is that a person with psychosis and taking psychiatric medication should not have to live a lifetime of physical illness to achieve good mental health. We need people to be supported in these two components. And someone like Enrique that is starting his trajectory of mental health, that to achieve good mental health, it doesn't compromise his physical health, that we can work on both sides of the equation as we're doing that. And to end our talk today, I know I have like 10 more minutes, we need to talk about the elephant in the room as well. So we've talked about how to address issues in the care coordination, how to address health behaviors for people with serious mental health, how to integrate services for prevention. But we need to also think about community and community level modifiable factors, in particular stigma. And as many of you know, stigma is a mark of shame, tainted and discounted. It's enacted in social interaction. It lives in how we interact with each other. Stigma, and there's been great work, is linked to unfavorable attitudes, beliefs, and stereotypes. It results in people with mental illness being devalued, excluded, discriminated against. And stigma is one of the things that is universal, but it's also specific to individual culture, meaning every culture stigmatizes the other. but the way that they go about doing that and how stigma gets expressed is very culturally nuanced. So we need to address those elements from a cultural perspective. There's some great work indicating that stigma is a fundamental cause of health inequity. As you can see here, it permeates through the entire healthcare system, from the lack of investment in our public mental health system to lack of parity and fragmented care that we're seeing, from the patient side of things, avoiding care, poor treatment engagement, and from the providers thing. Providers also stigmatize clients due to differentiation. And let me give you an example of how this work really intersected with the health of people with serious mental illness, with the story of Marco. Marco was a Puerto Rican male with schizophrenia and diabetes when he participated in one of our focus groups. And when we asked him to describe our negative healthcare experiences, this is what he told us. One time it happened in the hospital. My stomach hurt. I kept telling them, they just gave me a Tylenol. I ended up passing out and it was my appendix. They just didn't believe me. Marco's experience captures a common reality for many of our participants in which medical providers dismissed their medical complaints because they were identified as having a mental disorder or taking psychiatric medication. This is an example of diagnostic overshadowing, in which the psychiatric disorder overshadows the physical health complaints and leads to misdiagnosis and poor quality of care. That this is not because providers are bad providers or anything. It's because of the type of training we provide providers, of the structures that are around when we provide these services. So we need to address the stigmatization from the provider side as well to help address this issue. So my last call to action as we come to an end to this talk is to really understand and cross stigma at all levels, through advocacy, through education, through research and contact-based intervention. And this is one of the areas that our team is really moving forward with a recent grant from the Washington University Center for the Study of Race, Ethnicity, and Equity, and in partnership with one of my doctoral students and social work and NIMHD 32 fellow, Nancy Perez-Flore, we began to develop this Latinx collaborative to reduce stigma and improve mental literacy. We have different entertainment education approaches that we're trying to disseminate and study. This depression photonovela you see here. The other example here is from great colleagues at UCLA, Mary Sue Hellman, who's created a really interesting transmedia approach to deliver mental health literacy and actually depression treatment to Latinas through the web and through apps. We're also hosting a lot of talks on this topic, and we're developing a new partnership with a colleague from Puerto Rico to really tackle this issue of stigmatization that happened from primary care. This is the work that's being done by Elio Rivera Segarra from Ponce Health Science University in Puerto Rico, who really identify the importance of reducing stigma that happens in primary care for people with serious mental illness, and really trying to figure out a way of addressing and training providing them the right training to address the stigmatization. So what he's doing right now with a grant that we have from the National Institute of Minority Health and Health Disparity is to embed this anti-stigma module for providers in which is using short videos to teach providers about positive and negative interactions with clients, and then provide them the skill set and the feedback on how to address some of these issues, and embedding that within our healthcare management intervention as a way of addressing this. So in the end, we've talked about 4 major areas to achieve health equity. We integrated models of care need to be the norm, not the exception for people with serious mental illness. We need to move beyond our clinic walls and bring interventions into the community where people live. In the area of first episode psychosis and for emerging SMI, we need to move beyond not just screen and monitor, but intervene from the very beginning, beginning to integrate health promotion from the very beginning of the illness. It is, I think, as a mental health provider, it is our call to do that. If we're providing people medications that are going to impact their physical health and improve their mental health, we need to make sure that they're well supported for their physical health and health promotion. And lastly, we need to cross stigma at all levels. More and more, this is a major barrier that has persisted over decades, and we need to do a better job, particularly in minoritized communities, by bringing more information, more education, more contact-based approaches, more advocacy to reduce the levels of stigma in our community and empower people to seek care. So I want to end my talk. I think the time for action is now. As you've seen, I hope the talk has provided you examples of how our team is really trying to put these principles into action. And I want to end with this great talk, a great quote from one of my colleagues here at Washington University, Dr. Vera Thompson, is a good colleague at the Brown School, who I greatly admire and for her dedication and work in eliminating health inequities. And I think she encapsulates sort of the work that we need to be doing. To achieve equity, we must be willing to intervene directly on the social determinants of those inequities, but we also need to intervene in the practices and the policies that sustain the system of inequity. And that directly talks to how we go about doing our science. That is not only about the questions that we do, but also how do we go about the science that we do, how do we engage our partners, how do we not forget the people that we're supposed to be serving and engaging in a science that benefit them. That, I think, is what drives our work and what's needed in these discussions of equity, that we also need to think about how we go about doing our science to address these larger issues. If you're interested in this work that we're doing, please visit our translational science benefit case study. This is a great tool developed by colleagues here at Washington University. You can scan this little code. Actually, it should be live until tomorrow, I think. And it really highlights, it's a great way, a great tool of communicating the science that we're doing to larger audiences. And this is a major area that we are very concerned about in our team. How do we communicate the science that we've been doing to larger audiences beyond the academia and present sort of the value that we're doing? So this is a great tool that is beginning to be used across different implementation science projects that creates tools for communicating the science, creates very short one-pagers that describe what we do and the impact that it's having and the expected impact of this work. So with that, I want to end and thank you so much for this opportunity. I'm hopefully we can have a lively discussion in this half an hour. Happy to take some of your questions, and thank you and gracias for this opportunity.